Good afternoon, everyone. Time is 12 o'clock, and let's start our session for today. And I will welcome everyone for today's webinar presentation, Fall Preparedness, Respiratory Infections Case Scenarios for Long-Term Care. My name is Boris Marufov, and I am a team lead in IPAC at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin with today's session, I will mention some housekeeping items. To enhance the presentation experience, participants' audio video has been disabled. The chat pod has also been disabled to limit any distractions during the presentation. Please use the Q&A pod you see on your screen if you have any questions during the session. And discussion and question period will follow at the end of the presentation. At any point during the session you experience any technical issues, please email at capacitybuilding@oahpp.ca. And this presentation will be available on the PHO website in about 2-3 weeks from now, so you will be able to see and then review it if you want. I have to mention that this session will focus on IPAC perspective to the scenarios discussed and will not address staffing and supply issues, which should be addressed by appropriate channels. So now it is my pleasure to introduce the speakers for today's session, Rhodora Laylo and Tanya Denich. Rhodora Laylo is an IPAC specialist at Public Health Ontario. Prior to joining Public Health Ontario, Rhodora worked in infection control for 15 years in various healthcare settings in the London area. Her strength in the areas of policy and program development, education, is strongly committed to collaborative practice. Rhodora graduated with a degree in biological science and medicine from the University of the Philippines, the La Salle Medical Health Sciences Institute, and has maintained certification in infection prevention and control since 2008. Tanya Denich is an IPAC specialist in Public Health Ontario as well. Tanya has been an infection control practitioner since 2007 and was the IPAC lead in various acute care settings, including emergency department, operating room, and medical device reprocessing, maternal child, complex care, and critical care units. Tanya holds her Bachelor's of Science from University of Waterloo and Master's degree in microbiology from University of Guelph. So with that, now I will ask Rhodora to begin the presentation for today.
Thank you, Boyce, and welcome everyone. I'm Rhodora and I will start the webinar and then hand it over to Tanya for the next half. So this presentation was developed to assist homes in increasing their internal capacity in order to respond to common situations and scenarios that may occur during respiratory virus season. We will start by going over the objectives of this session. So by the end of this session, participants will be able to integrate the infection prevention control guidelines from Public Health Ontario and the Ministry into their home's fall preparedness plan, use and discuss the scenarios presented here with their teams to assist in ensuring homes are prepared for any types of respiratory infections, seek the support from Public Health Unit, IPAC hubs, and other partners as needed. In this coming respiratory season, we anticipate the co-circulation of COVID-19 as well as non-COVID-19 respiratory viruses such as influenza, parainfluenza, and respiratory syncytial virus or RSV. As per the Minister's directives, homes should ensure measures are taken to prepare for and respond to COVID-19 outbreak, including ensuring the development and implementation of a COVID-19 outbreak preparedness plan. This plan includes identifying members of the outbreak management team, identifying local public health unit and IPAC hubs as well as their contact information, conducting regular IPAC audits, and ensuring that there are sufficient supplies of testing kits and personal protective equipment, as well as a plan in place to collect for specimens as well as testing. The plan also includes IPAC training of staff, students, volunteers, including the proper use of personal protective equipment, updating and reviewing policies and protocols, and a communication plan with frequent and ongoing communication during outbreaks. So you will see on this graph the number of institutional respiratory outbreaks by viral pathogen during the 2018-2019 season, which was prior to COVID-19. You will note on this graph that although majority of the outbreaks were from influenza, there were other respiratory viruses identified during that time frame. For this year, homes should be prepared for a number of scenarios with outbreaks caused by more than one pathogen, including COVID-19. So for today, we will go over 4 case scenarios developed to assist homes in ensuring their existing plans are comprehensive, feasible, and workable during the actual outbreak period. The key outcomes are aimed at identifying gaps and strengthening preparedness. The scenarios can be used by leadership team or the outbreak management team that may include representatives from public health unit and IPAC hubs as part of the fall preparedness. By working through the scenarios, homes might identify gaps that need to be modified or changed, and also develop an action plan to enhance the level of readiness. We will work through these 4 case scenarios and provide guidance on managing each case. Let's go to our first case scenario. So our first case scenario is outbreak identification and cohorting of residents. So for this one, as an IPAC lead, you were notified, you received report from the units that there's an increase in residents reporting sore throats and congestion. Additionally, your occupational health and safety lead has informed you of a number of staff with similar signs and symptoms. You suspect respiratory outbreak. How do you determine if you're on outbreak?
Well, Rhodora, just looking at this case scenario, we know that residents have signs and symptoms of a sore throat and congestion. There's also a number of staff reporting sick. How would you go about determining if you're an outbreak, if you're the long-term care lead in this home?
Thanks, Tanya, for that question. So I would begin by line listing of residents who are ill with respiratory signs and symptoms. And this is based on the information collected through our daily surveillance program. We know that daily surveillance or monitoring is essential to identify new signs and symptoms or exacerbation from baseline signs and symptoms. Monitoring is also increased during outbreaks. I would also do a separate line listing for staff who presents with similar signs and symptoms consistent with respiratory illness. Another immediate action I would do here, Tanya, is the prompt initiation of additional precautions for symptomatic residents. After that, I would then notify my local public health unit. I know that public health unit will provide assistance in investigation, confirmation, and management of the outbreak. During this time, public health unit will also provide an outbreak number, which will then allow testing priority and expanding testing, including rapid influenza testing. We know that testing is an important component in managing an outbreak, as we have noted on the polling response, although identification of a specific virus or pathogen is not required to declare an outbreak. Public health unit will assist homes in identifying residents that need to be tested. It is important to ensure and remember not to test just for COVID, but for other respiratory viruses. During an outbreak, specimens from the first 4 symptomatic residents in an outbreak will be tested using the multiplex respiratory virus PCR or MRVP. Additional testing for other respiratory viruses in residents with acute respiratory illness may also be indicated in some situations, and that is following consultation with your public health unit as well as the public health laboratory. It is important to note that regardless of the identified virus, or if there's no virus identified during the outbreak, we should continue to test for COVID-19, and that is done for all residents with an acute respiratory illness or other COVID-19 signs and symptoms. Now, Tanya, with regard to declaring an outbreak, there is a case definition that is followed, and we can use the Ministry of Health's case definition and disease-specific information document. This is based on the number of ill residents, signs and symptoms presented, as well as a laboratory confirmation. An outbreak will be declared by the health unit. You can refer to this document on Appendix A, case definition and disease-specific condition for more detailed information. So now results are in, and based on the results of laboratory testing, your local public health unit declares an outbreak of COVID-19. Some of your residents that have tested positive for COVID-19 have roommates that have tested negative. So how can you cohort your residents, and how would you cohort your staff?
So Rhodora, now your test results are in and your local public health unit declares an outbreak of COVID-19. Some of your residents who tested positive for COVID-19 have roommates that have tested negative. How would you go about cohorting resident staff in this situation?
Yeah, so, as I've mentioned earlier, one of the initial steps that you have to do here is putting patients or residents on additional precautions. So additional precautions and cohorting are strategies that should be included within your outbreak preparedness plan. Cohorting is one of the many layers of infection control measure available to prevent further transmission of infection, whether it's COVID or other respiratory viruses. The local public health unit will be able to help define the outbreak area and the non-outbreak area. We know that while homes are no longer required to directly set aside beds for this purpose, whenever possible, a single room must be used for residents requiring additional precaution. So, in this situation, there are several units reporting ill residents and not just one unit. The priority in cohorting is separating the outbreak area from the non-outbreak area, if there is a non-outbreak area. Within the outbreak area, you separate the exposed, well, and non-known to have COVID as one cohort. The other cohort is exposed, ill, but not known to have COVID-19. And the last cohort is COVID-19 positive and infectious cohort. Since the roommates in these situations are considered close contacts, they should be placed in a private room with private bathroom, if at all possible. If that is not possible, they can be roomed together, but as far apart as possible, at least 2 meters apart at all times. COVID positive residents must be separated from exposed residents. If possible, the 2 positive residents can be placed in the same room, and the exposed roommates can also be cohorted. This is something that you can always discuss with your local public health unit, of course, as well as your outbreak management team.
So Rhodora, thanks for that great review. And it's definitely important to have cohorting strategies in place as part of the outbreak preparedness plan. How about your staff? Would you consider cohorting staff as well in this case?
Yeah, so, part of, again, the outbreak preparedness plan is the home should have a plan for cohorting staff as part of their plan. Considerations for staff cohorting includes cohorting staff between outbreak and non-outbreak units, as those the ones that you have identified. Consider the possibility of staff members working in one unit only. Other considerations include staff assigned to care for only one cohort of residents during each of their shifts and subsequent shifts, if at all possible. Organizing workflow so that it is grouped together to minimize repeated visits to the same cohort. Consider bundling your tasks to minimize multiple visits to residents. If staff must move between the cohorts, they must go from the lowest risk cohort to the highest risk cohort, if that is at all possible. This is from resolved cases, non-exposed well residents as the lower risk cohort to the exposed ill and COVID positive residents as your highest risk cohort. We always need to ensure a minimum level of care is provided by minimizing the number of staff that move between cohorts and controlling the direction of flow. So it's very important cohorting of residents as well as cohorting of staff to minimize or prevent further transmission of the outbreak. So I hope I was able to give you some guidelines in cohorting of residents and staff. So we'll hand it over now to Tanya for the remaining of the presentation.
Oh, thanks for that, Rhodora. Yeah, for the next part, we're going to talk about keeping staff healthy. And we know that keeping everyone safe is important at all times, but especially during, the winter season, or some people call it respiratory virus season. So we do want to make sure that we're doing everything we can to keep our staff healthy. So in this case, you have a respiratory infection outbreak has been declared at your long-term care home. You observe an increase in staff calling in sick, reporting respiratory infection symptoms. You are concerned there may be gaps or barriers in compliance with IPAC best practice that are leading to staff illnesses. How do you determine if proper IPAC practices are being implemented?
So Tanya, there are concerns with compliance and following proper infection control measures in the home. How would you determine if proper IPAC practices are being followed, and who should complete the tools, and what's the frequency of auditing during outbreak?
Yeah, thanks for that, Rhodora. So the PPE auditing tools, the PHO has a bunch of auditing tools, a whole suite of them that you can see on this slide to help with your IPAC best practice. So we can see that we have PPE audit tools, hand hygiene audit tools, as well as your COVID-19 self-assessment audit tool and your COVID-19 infection prevention and control checklists for long-term care retirement homes. Now, remember that COVID-19 self-assessment audit needs to be completed every 2 weeks when your home is not an outbreak. So you're probably really familiar with that tool. But while your home is an outbreak, you do need to complete it weekly. However, the COVID-19 infection prevention and control checklist for long-term care retirement homes is recommended to be completed if it hasn't been done recently. Keeping in mind, it may have been done by your IPAC hub or your public health unit, or maybe by your IPAC lead at your home. So just have a look at that. So the strength of auditing is, when audits are completed, that any gaps are identified and presented to the leadership at the home, as well as the outbreak management team for resolution. As well, those audit findings need to be communicated back to frontline staff. And I think that's really the power of auditing, is really that full circle from leadership to outbreak management to frontline staff, that full 360 communication. So I think that's really key here. The home's IPAC lead or trained staff can conduct the audits, as we mentioned. However, if the home does require any additional help with auditing, they should contact their IPAC hub or their local public health unit who can assist with that. And it's often good to have a few sets of different eyes doing the auditing. So folks from different disciplines, the hub, as well as the IPAC lead at the home, just to have all those different eyes, all those different viewpoints auditing from different perspectives. So this support with auditing can be discussed and organized during your outbreak management team meetings.
So Tanya, we know that outbreak is difficult and challenging for everyone, especially the last 2 years. It's important to keep the morale of staff and recognize the work that they do. How can you support staff and ensure IPAC practices are being followed?
Yeah, Rhodora, I think the choices presented on the previous polling questions are really good strategies and opportunities to support staff. And we're going to talk about some of those options now. I would ensure that staff are supported to follow IPAC best practices. For example, that PPE and alcohol-based hand rub are readily available. And I would ensure that there is proper placement of ABHR and PPE that are easily accessible at the point of care, at entrances, and at break spaces. Another factor to consider when supporting staff are those break spaces set up to facilitate distancing so that staff can really enjoy their breaks in a safe manner. As well, all new agency staff and all new staff should ideally have received the full IPAC training before starting, such as the IPAC core competencies that you can see the link on this slide prior to starting work. IPAC education should be received at the point of care, a point of hire, but also on an ongoing basis. So that's really important to have it at the point of hire and an ongoing basis. Staff meetings and huddles with staff are another good way to support staff to provide reminders of key IPAC information. There is a good resource you can see on this slide that you can use to guide you. It's called Healthcare Huddle IPAC Checkpoints, and it's also in the resources section. So that can really help you to outlay how you would do a huddle or and highlight key IPAC points. Newsletters can also outline successes and concerns, review of current outbreak situations, any gaps identified during audits. And newsletters can also serve as a reminder on correct PPE use, the need for prompt initiation of additional precautions, and reminders on the 4 moments of good hand hygiene and good hand hygiene technique. As well, email is another way to provide frequent and ongoing communication on the status of the outbreak, as well as share any gaps identified during auditing. Another good way to support staff is by re-education and retraining. Homes should have a plan to ensure their own staff, as well as agency staff and any other staff identifying their contingency plan, receive ongoing IPAC training. And there are online education materials available on the PHO website to support this IPAC training. Something else I may think about, Rhodora, as the IPAC lead at this home is if there's a plan to use workers from non-healthcare settings to assist with things like meal delivery or other tasks, how will the home ensure they're properly trained? Is there an opportunity for these staff to be trained in advance? And so that's really important to think about. And I think another key way to support staff, especially with that on-the-spot feedback, is to use it as an opportunity to provide constructive feedback, but also positive feedback. So, while you're doing your auditing, if you happen to notice staff who've missed a moment of hand hygiene or maybe aren't wearing their PPE correctly, just taking that moment to say, hey, I notice you've had a little gap there with your hand hygiene, your PPE wearing, and how can I support you? Is there anything, in the setup of the home that we can improve, or is it a re-education or retraining moment there that you can do at on the spot? Also, just to use that on the spot feedback to provide positive, reinforcement to say, I notice you're doing a great job with your PPE and hand hygiene. And I think that really goes a long way to promote that culture of safety, because really that's what, auditing is supposed to do, create that culture of safety, promote that IPAC best practice. That's everyone's responsibility. And, under the context that we understand that there's the burnout issues out there, but we really want to just provide some learning opportunities to staff with this on the spot feedback.
Thank you, Tanya, for laying out all those excellent strategies.
So we'll just move on to the next case on how to respond to positive cases in your home. So just in this case, the IPAC lead is made aware of 2 staff members with positive COVID-19 rapid tests. The 2 staff members work on the same unit, carpool to work, and work the day before. Both staff are showing symptoms and are up to date with their COVID-19 vaccinations. How do you perform a risk assessment for exposed contacts? So the next scenario here is the co-circulation of viruses. So over the past few years, we've been mostly seeing COVID-19. However, this year we do expect to see a greater return of other respiratory viruses. So we just hope to prepare for this with this scenario. The long-term care lead at the home has been monitoring a resident with respiratory symptoms. COVID-19 testing and multiplex respiratory virus PCR was done and influenza A was detected. The next day, 3 more residents were identified with respiratory symptoms and an influenza outbreak was declared. Additionally, 1 resident tested positive for COVID-19. What were your next steps?
So Tanya, what would be your immediate steps in this scenario where there is co-circulation of viruses?
So, Rhodora, I think the key to remember here is an outbreak caused by more than one agent is really not handled differently than any other outbreaks. And the key principles that you reviewed in scenario one really still apply here. And I think that, homes need to be prepared in their fall preparedness plans for outbreak caused by more than one virus. So, but the really key difference I want to highlight is that multi-virus outbreak is the need to differentiate between the two pathogens on a resident by resident basis to help facilitate the cohorting. So in this scenario, I would remember again that prompt initiation of additional precautions is key in outbreak management as always. And then I would notify the local public health unit, and then a meeting would likely be held to review outbreak management with your local public health unit. And some points to discuss at the meeting are, again, who will interview staff cases? Will it be staff from the home or the public health unit? As well, in conjunction with your local public health unit, you will continue to implement IPAC measures, and those will include isolating ill residents on additional precautions, reinforcing hand hygiene, and the auditing and observation of staff use of PPE, and enhanced surveillance for new cases. So those are some of the things that we would want to do. Some other IPAC measures that will also be implemented would include enhanced environmental cleaning and cleaning of high touch surfaces. As well, cohorting plans will be modified to ensure that COVID-19 cases and contacts are cohorted separately from residents with influenza. Homes will need to rely on testing to differentiate between the two pathogens on a resident by resident basis, so you can really keep those different cohorts separately, those with influenza and those from COVID separate within your home. So that's really key there to initiate that testing strategy. You also want to just keep in mind that the differences in workplace exclusion for different viruses, and we chatted earlier about that COVID-19 management. But just remembering, we haven't seen a lot of respiratory viruses for a while, so that remember respiratory virus positive cases, things like influenza and RSV also need to be placed on additional precautions, and the high-risk contacts for those viruses need to be monitored for development of signs and symptoms of infection, of respiratory infection. As well, Rhodora, you'd want to consult with your medical director of health and initiate, or your medical director at your home, and initiate any antivirals. So in the case of influenza, that would be Tamiflu, but Paxlovid for COVID-19. And you'd want to follow your home's policy for the management of staff that are unvaccinated for influenza, and as well contact your IPAC hub if any additional support is required, and then I know they're happy to help. And just a few more points that I'd just like to cover. Also remember, when providing care to a resident with symptoms of a respiratory illness, when you don't know what the pathogen is, you really need to remember the PPE you need to wear is eye protections, goggles or a face shield, gloves and gown, and a fit, tested, sealed, checked N95 respirator. A well-fitted medical mask instead of an N95 respirator is also considered appropriate based on your PCRA, your point of care risk assessment. And then in an outbreak when the pathogen is known and it's not COVID-19 and there's no evidence of ongoing transmission, for example, no newly identified residents with symptoms of a respiratory illness, care providers should wear PPE in accordance with current best practice recommendations for that specific organisms. For example, in this case, we were talking about if you had an influenza or RSV outbreak that we kind of highlighted earlier, the recommendation is for care providers to wear eye protection, goggles or face shield, gown, gloves, and a well-fitted medical mask. And of course, follow all your ministry guidance. So, when you don't know what the pathogen is, you need to wear your N95 respirator, gloves, gown, and eye protection. But if you do know, you can use the best practice guidance for that corresponding organism. So we are now moving on to the Q&A section, but first Rhodora will review the resources at this point.
Thank you, Tanya. So, we have really a good amount of references here that are on the slide. So, some of them are from the Ministry of Health, the Ministry of Long-Term Care, as well as there's a host of Public Health Ontario documents specific for long-term care homes that will be able to help you put together an outbreak preparedness plan, as well as manage the different scenarios that we have presented here. So it will all be available once this slide deck is available and the presentation is available. And you can always refer to the Public Health Ontario website for additional resources on COVID-19 as well as other respiratory viruses.
Okay, so let's move to our Q&A section. Thank you very much, Rhodora and Tanya, for your insights and discussions about the scenarios. So if you please continue to put your questions into the pod if you have not done already, and we will go from the first ones and down, and some of them were answered already. So let me look at the first one now. The question is about the audits. My understanding is that the intervention is audit and the feedback. So the person is asking if you can talk about the importance of providing a feedback and an evidence behind that on behavior change.
Yeah, with regards to auditing, I think, really you can see those trending over time is really the strength. So, tracking your hand hygiene, your PPE audit week over week, month after month, really speaks to when you present that data to staff or to your management, can really seek to change behavior because they can see that data collected over time, as well as we mentioned in the presentation, that on-the-spot feedback with your frontline staff can really help to strengthen the practice when the practice is fresh in their mind, either the gap or the positive, adherence to best practice that we see. Then we can reinforce the good behavior and then correct, any gaps that we identify. So it's really, if you use those two in conjunction, that planned feedback where you, display on your quality boards or through newsletters, your data through time, but also combining that with your on-the-spot feedback really seeks to strengthen and promote that behavior change, as well as maybe having peer champions or administrative champions that could, take that role forward and just show, be an example of IPAC best practice and really promote that culture of safety and that IPAC best practice. Rhodora, I don't know if you wanted to jump in there. So,
I think you've covered everything. It is very important that we provide that feedback in a constructive and respectful manner, so that we can change our practice. We all get busy in our day-to-day activities. We get busy. We get so focused on providing care, and of course, nobody is intending to forget infection control practices. So it's just a gentle reminder, even between peer-to-peers, as Tanya mentioned. It's a good way to learn, as well as ensure we're following good infection control practices.
Okay, thank you very much. And there are several questions around the dedicated isolation rooms. If you, Rhodora, maybe if you can clarify on those, and the questions around what if, first of all, that there is no required isolation room now, and then other thing is that all beds are already 100% occupied, so what we can do. So if we can talk about the planning, for the planning purposes, what they need to do and how to collaborate with public health units on that.
Yeah, sure, boys. Thank you. Yeah, so we know that the homes are no longer required to dedicate isolation rooms for purposes of COVID-19 or other respiratory viruses. However, of course, there is still a need to place residents who are identified with COVID-19 or influenza or other respiratory viruses, or who become symptomatic, on additional precautions. And with additional precaution, that comes the requirement for isolation or placing patients in a private room. So that is always the priority, whether we're dealing with COVID or non-COVID. The priority for placing residents on additional precaution is on a private room. If that is not, of course, possible because of what you mentioned, your maximal occupancy has been achieved, you really have to look at your residents and who's symptomatic, who's confirmed with COVID-19 or other respiratory viruses, who were exposed and who are still well and not in kind of that outbreak area. So you can do is, you think about your cohorting strategies, and this is something you definitely need to work with your public health unit, collaborate with them, and to think through how you're going to isolate the different patients. So there's risk and level of prioritization when you're cohorting or isolating residents. And if there's really no private rooms, the other consideration is putting them in a room, a wardroom, or two-bed wardroom, but always put in consideration the physical distancing. So there's always the physical distancing. You can put two beds foot to foot or foot to head, so that you maintain that 2 meter distancing, because that will minimize the transmission, and as well, providing staff with reminders that when they're going from one area or one cohort to another, that they must put a really strict infection control measure in place, such as making sure their personal protective equipment is changed in between cohorts or between residents. Tanya, if we can, is there anything else to add to that?
Yeah, I think, Rhodora, everything you brought up is a very good point. I think this is time as we head into, fall and into respiratory virus season, really, participating in some of those exercises, planning exercise, fall preparedness plans to see, what resources you have in your home, what spaces you have, and how you will go through these different scenarios as you've just outlined. So really kind of just thinking that. I know, some places are even practicing like tabletop exercises in these, and I think this is a really good time to do the planning documents, but also really just kind of walk the physical layout and looking at what's available to you and what you could do in your home. So I think, yeah, you've covered pretty much everything, and I think that would be another idea I would have.
Okay, thank you, Rhodora and Tanya. And maybe, Tanya, if you can look at this and answer question about the MRVP is only for the first influenza cases, and do we include all symptomatic but negative residents on the influenza line list? And this is for the COVID and influenza combined outbreaks. Maybe combining these combined outbreaks of related questions into one, if you can answer that, how the cohorting will work when the influenza and the COVID is combined situation.
Yeah, so I think, as we mentioned in that last case scenario, you really need to rely on your testing strategies to really differentiate. So, a lot of people are promoting the use of the multiplex PCR to really differentiate, COVID from non-COVID. So we really need to have that in place as well. Usually when an organism is identified, you want to test, when residents become symptomatic, you do want to initiate that testing. And from there, you will test all symptomatic residents and initiate precautions. And from there, you can isolate them as according to their cohort. So COVID-19 separate from those with influenza, and as well as any contacts identified by public health of COVID, you will have those cohorted as well. And, Rhodora had a nice slide pulled up with regards to the prioritization of the COVID-19 contacts and how those will be cohorted in those separate cohorts. So we could refer back to that to separate the cohorts there. So I hope that's answering the question, boys. Is there anything I've missed there? Just trying to review. It was a longer question. So I don't know, Rhodora, if you had anything to add.
Yeah, so as Tanya mentioned, the MRVP, we use that to test for COVID-19 as well as non-COVID-19 respiratory viruses. And I believe there's additional questions about that as well, whether, there's, I mentioned about 4 specimens being collected, but that is, of course, not set in stone.
Yeah.
There's always, that discussion with your local public health unit as more and more cases come up. If outbreak is ongoing, there's always, you need to continue your discussion with your local public health unit in terms of testing requirements. It is requirement, though, that if anyone becomes symptomatic, that COVID-19 testing is still being done. But if there are already outbreaks are resolving, another probably measure needs to be in place in terms of testing and or no testing requirement at all. But definitely, I want to emphasize that 4 specimen collection, the first 4, that's not set in stone. There's additional considerations to that.
Yeah, thank you, Tanya and Rhodora. And probably, if I understood properly, the question was about the 4 specimens only. The reasons behind is pretty simple. If you have 4 specimens already confirmed, then you don't need to, more testing, because it's enough to declare outbreak, right? So that you use appropriate additional precautions and all of that, and cohorting, to deal with that type of a situation, I guess. So let's move on. And some questions are not related to this session, and some of them we cannot answer because it is not our mandate to answer them, about why isolation beds were removed, the requirement and all of that. So it is not the subject of today's discussion. And I move to the next question, which is around the universal use of N95 masks. And if we can summarize that all related to the universal use of N95 mask, whether there is a need or not, when N95 masks, the respirators rather, should be used. If Rhodora, can you answer this question, please?
So the N95 mask, is part of the personal protective requirement for suspect or COVID-19 patients. And if there are any residents who are symptomatic and we still don't know what they have, or the pathogen has not been identified, then the N95 mask, together with other personal protective equipment under drop-in contact precaution, is the one that it's recommended. Of course, staff should continue to do their own risk assessment, so your point of care risk assessment, and that is a requirement for every staff, or routine for every staff, to conduct a point of care risk assessment whenever they're providing care for a patient. So that is where you use your N95, or based on your point of care risk assessment, additional personal protective are being used. And just want to add, boys, there really is a good reference within Public Health Ontario about the personal protective requirement or recommendations, sorry, for suspect or COVID-19 cases. Now, if your outbreak identifies a different pathogen, non-COVID pathogen or other respiratory viruses, again, then an alternative personal protective equipment based on your risk assessment may be used as well.
Okay, thank you. Maybe another question about the outbreak. It's Tanya, if you can answer that. If COVID and other respiratory outbreak was declared, so is it considered one outbreak or two?
Yeah, so I mean, I think for this, they would probably have separate line listings for different organisms with regards to public health. So you would have your COVID positive cases in the case of a COVID influenza outbreak, your COVID cases, COVID suspect cases, then suspect COVID and influenza until it's differentiated, and then a positive influenza cases on a separate line list. So in that case, you may, I mean, you would have to talk to your local public health unit, but I think that would be a reasonable way to differentiate COVID-19 cases from influenza cases than those that are suspect or undetermined at that point. So moving up forward that way. I think in terms of IPAC, the thing, we really want to focus on is that, wearing your personal protective equipment, as Rhodora kind of highlighted in the last question, is wearing that N95 respirator and eye protection goggles or a face shield, gloves and gowns when you have someone who's undifferentiated, you don't know the organism. And then, when you know the organism, so in case of influenza, then you will be able to manage them with the best practices, the PPE best practices for that organism. And for influenza, that would be, your well-fitted mask, eye protection, gloves and gowns. So just, deferring to that first level of protection when you don't know, with the N95 respirator, gloves, gowns, and eye protection when you don't know and it's undifferentiated. So I hope I've answered the question there. Rhodora, did you have anything to add there, or boys?
Yeah, if I may just add, so if there's a COVID-19 or other respiratory viruses, and whether you declare that as two separate outbreaks or one outbreak, I think definitely that the public health unit will probably make that decision, make that call. And because if we go with COVID-19, of course, there's a different layer of personal protective requirements. So the assessment in terms of risk represents risks to the healthcare facility will be under the public health unit, as well as, of course, in collaboration with the home's outbreak management team.
Okay, thank you very much. And we are almost at the end of our session for today. And as we wrap up today's webinar, I would like to thank Rhodora and Tanya for presenting. I would like also to thank everyone who joined today's webinar. We will try to respond to your questions below because we were obviously not able to answer all of them. But unfortunately, we will be able to respond only with registered names. We will not be able to respond to anonymous questions. So you can expect to receive a brief anonymous survey for today's session. Please try to complete this to help us to improve our programming. And lastly, to access past presentations and view confirmed upcoming sessions, please visit the PHO website and head to Education and Events section and click on Presentations. You will be able to see all previous sessions and presentations, and may have find answer to some of your questions below. So by this, I will end today's session, and thank you very much for participation one more time. Bye.